Okay. So we can look at the stats for the exam. So the average score is going to be 84, high score 98, low score 62. If we go through the questions, we can see basically everyone got most of them right. So we'll go through, we'll look at one. So this is the first one that people actually had differing answers on. So which of the following is not a lateral ankle ligament? So we know that anterior talofib and calcaneofibular are going to be lateral. So deltoid is always the medial, so that one will be correct. This one really screwed up people. In anatomical position, what position is the ankle in? So 54% of you got dorsiflexion correct. But if you think about when you're standing, your foot's in a 90-degree angle. So you're always going to be at dorsiflexion. Any deviation from that would be plantar flexion. It's aggressive. You're not going to have any inversion or eversion while standing unless you have an issue. Which of the following muscles is not a plantar flexor? We know that peroneus longus is a plantar flexor. Soleus and gastroc are the easiest two because they're posterior, and we know all posteriors are going to be plantar flexors. So even if you didn't know which one was right, you're going to know that anterior muscles aren't plantar flexors, so that one's the easiest. You can just pick without even having to really know what it does. These ones, some people just got them wrong. Most of you guys got them right. Same with these ones. I know some people had a hard time, their images wouldn't load. Okay, so we have the matched muscle to the letter. So obviously tibialis anterior is going to be A, so it's the most medial of all of the muscles. And extensor hallucis longus is going to be E, because if you recall, I talked about trying to follow it down, tracing it to the tip of the toe. So that was a trickier one. Which of the following muscles is not pictured on the image? Pretty easy, because we know tibialis posterior is on the posterior side. So there's no way we would be able to see that. Peroneus longus you actually can still see on the side, but we know for sure we're not going to be able to see tibialis posterior, and we know that tibialis posterior is the deepest of all of the posterior muscles, so it's definitely not going to be there. Match the letter to the bone. Everyone got those right. Anterior cruciate ligament prevents what? Most everyone got that right. Anterior displacement of the tibia. MCL originates on the femur at, so we know it's going to be adductor tubercle because Gerdy's tubercle and tibial tuberosity are on the tibia. So off the very front, you can eliminate those two because it says the word femur in it. So then that should get you between lateral epicondyle and adductor tubercle. Lateral epicondyle has the word lateral in it, so we know the medial collateral ligament is not going to attach there. So most of my questions can actually be answered through process of elimination without even knowing. Medial lateral menisci attach onto the tibial plateaus. So remember those flat portions on the top of the tibia. Tibial tuberosity, no, because we know that's kind of halfway down the shin. Intercondylar notch would be on the femur. Which of the following muscles are not knee extensors? Out of these four, this is the only one that is on the posterior side. So we know vastus lateralis, rectus femoris, vastus intermedius are all on the anterior side. Therefore, they're all knee extensors. So this is posterior, therefore it's not. Most people got these ones right. Just identification. Okay, we got this one, which pretty much everyone got them right except for a few people. So rectus femoris is obviously going to be number 4. What muscle performs the figure 4 position? I think I said this like a gazillion times. So sartorius, remember that Faber, the flexion, abduction, external rotation, figure 4. And there's the answer. So knee flexion, hip abduction, external rotation, hip flexion. Some people didn't answer at all. That's interesting. So I know a lot of people do this. They will pick both. So they'll pick knee flexion and knee extension, but you can't have one. If something's doing opposing action, a door can't be open and closed. It's either open or it's closed. Everyone got this one. People struggled with this one. So during anterior pelvic rotation, the ASIS tilts backwards. So again, you don't even really need to know anything about this. So we know that the anterior pelvic rotation means the pelvis is rotating anteriorly. We know that ASIS is on the anterior side. So if we think an anterior pelvic rotation, it's never going to tilt backwards because that would be posterior. So that would be an easy false. No, they're all good. Not sure why people didn't get that one. So when performing a squat, the hips are performing what when lowering to the ground? So obviously when we perform a squat and we get down, our hips are going to be bent, therefore we're in flexion. Abduction and adduction kind of depends on the girth of your squat, but honestly flexion is the most correct answer. This picture is kind of blurry, but most people got it right. Well, I see an error on this one. This is good where you can review it because you can see. So this one, the numbers got messed up. So semimembranosus is number 3. So the 20 of you who got that right, I'll go in and fix it. Semitendinosus is number 1. So I'll go in and fix that. And then biceps femoris is number 2. So I'll go in and review and see how many of you got that wrong, and I'll give it back to you. And lastly, what is a potentially life-threatening injury to the hip? Impingement is not a life-threatening injury. It's basically just a bony overgrowth. Your hip mobility decreased. Versus we know that dislocation could be life-threatening because it could tear through that artery, could tear through the glute muscle and any kind of nerves and vasculature through that area. Okay. So you'll at least get a couple points back because I found that error, which is not too surprising. Making these tests on Canvas is actually much harder than you think it is. Okay, so we are going to be moving right along into our next body part, which is going to be our neck and our trunk. So we kind of know, obviously, this is our neck. Our trunk is what you're going to think of as like your chest and your abdomen. So basically your whole like upper body is your trunk. So our neck is going to be made up of our cervical vertebra. So we know our spine. Everyone knows what the word spine is, right? It's made up of vertebra, and you're going to have specific regions of the spine. Let me get my skeleton. So the cervical vertebra will be our neck, versus our trunk is going to be kind of everything below the neck and before we get to our pelvic girdle. So it's going to be our thoracic vertebra, which is our mid-back. It's going to be our lumbar vertebra, which is going to be our low back. Our sacrum and our coccyx are kind of part of both the pelvic girdle and the trunk because they're the bottom of our spine. And then also our thoracic cage, and that is your rib cage and your sternum, which is like your breastbone. And we're going to talk more in depth about all of these. I'll give you a second to write it. Oh, this isn't available to you on Canvas, is it? Okay, there it is. So PowerPoint's open now. Okay, so with our motions, we're still going to be doing basically all the same motions. We're going to have flexion. So neck flexion will be tucking your chin to your chest. Trunk flexion would be bending over, kind of curling your back, touching your toes. So we know flexion is always going to be kind of curling in. Now, an interesting thing about your neck. So have you ever been sitting there on your phone or looking down at something for quite a long time and your neck starts to hurt? Happens to me a lot. Basically, when you're in kind of neutral 0 degrees of neck tilt, when you are standing straight up, the force on your neck is about the weight of your skull and your brain, so like 10 to 12 pounds. Every time you have a bit of neck flexion, so any degree of neck flexion, you're increasing the amount of weight on your spine, specifically your neck. So as I bend down to like 15 degrees of neck flexion, the force on my neck is now 27 pounds. And if I get to 60 degrees of neck flexion, so if I'm looking down like this, there's now 60 pounds of force being placed on my neck. This is what's actually happening often in texting, and it's actually creating a new bony landmark because people are looking at their phones so often. So as I've talked about before, all the bony landmarks, like the bumps and the grooves on bone, are caused by muscles pulling on them. And areas that are smooth basically mean there's no muscles attached. So what's happening is the muscles that attach to the back of your skull, as we're bending our neck, it's pulling, and we're actually seeing a new like bump in the back of people's skull, a new bony growth being formed because everybody's always looking down so much at their computer, looking down at their phone. So if you ever notice, if you get stuck in a position for a while where you're looking down, you'll notice your neck is starting to hurt, and that's because the amount of weight actually increases. So you should always, and that's why like if you're sitting at a computer, they talk about ergonomics, making sure that the computer is eye level with you so you're not having to look down and not messing up your neck. So extension is going to be standing straight up, basically. So not going back, but just staying in a straight line. It's going to be extension. Versus hyperextension will be arching all the way back. So tucking like the back of your head to kind of like your traps. And hyperextension of the trunk would be arching backwards. So we have flexion, extension, bringing you to neutral, kind of straight up and down. And then any movement past that is going to be hyperextension. We're also going to have lateral flexion in the neck and trunk. We don't have this anywhere else. So lateral flexion or lateral bending is going to be just kind of what it sounds like. So in the neck, it'd be like ear to shoulder, so kind of tilting your head side to side. And lateral flexion in the trunk would be kind of bringing your arm down the side, bending over to the side. We're going to have rotation in the neck and trunk. They're not going to be external and internal rotations. It will be right and left. So obviously, you know your rights and left. So rotating to the right side, my neck would be, I'd face that way. Rotating to the left, in my trunk, right rotation, left rotation. An important part because I will ask you things on the test about this, rotations and the directions that they're going, you need to make sure you're not projecting your left and right onto the image. So if I asked you, is this right or left rotation? Any guesses what it is? Right. It's right. So even though I'm looking at it and they're like, oh, it looks like they're going left, it's a reverse image of yourself. So always in anatomy, you need to imagine it's just flipped. So I was kind of, if I was confused in school, I would like literally position my own body in the direction that the picture was going so I could figure it out. Okay, so like I said, your spine is made up of vertebra. And the official fancy name for it is going to be our vertebral column. And it is made up of our cervical region, our thoracic region, our lumbar, our sacrum, and our coccyx. So you can see cervical, thoracic, lumbar, sacrum, coccyx. So within each region, we have, see this little number right here, 7, 12, 5. That's how many individual vertebrae make up that region. So we've heard me say it before, kind of the numbers like C1, C2, like T12. Those are the numbers of the individual vertebrae. So within cervical, we will have 7 cervical vertebrae, and they will be numbered C1 through C7. So anytime that we would need to figure it out, we can easily just look at our spine and count them out from looking either at the fronts or the backs. We can count and figure out, okay, C7, there's the cervical vertebra. Thoracic is going to have 12 vertebrae. So the number will start over. So once we get to C7, we'll then move to T1. So T1 through T12. T12 will be the last in this thoracic region. So again, you'll just count it out. So oftentimes you'll see, you can literally just kind of go, okay, 1, 2, 3, 4, 5, 6, 7. That's my C7. T1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And I get all the way down to T12 there. Lumbar has only 5 vertebrae. So L1 through L5, you can often start here. L5, 4, 3, 2, 1. And then your sacrum and your coccyx also are made of vertebra, but they are fused vertebra. So these are all separate units. So you could technically take one out and put one back in. Versus the sacrum, you can see it's all one big piece. So they are made up of 5 fused vertebra, and the coccyx is made up of 4 fused vertebra. There is a kind of mnemonic or a memory trick to memorize how many vertebrae are in each region, and that is the kind of trick of breakfast, lunch, and dinner. So breakfast, I mean maybe not for you guys, but for people who at work, they maybe eat breakfast at 7 a.m., lunch, 12 noon, and dinner at 5:54. So that's a way to memorize how many vertebrae are in each region. Okay. You may notice that your spine is not straight. Your spine is actually curved. Now, if you think about this kind of logically, as it is a curve, it's able to absorb forces a bit better. So if you had kind of a pole or a stick and you kind of hit it against the ground, the forces would just go straight up it. So if we had a completely straight spine, all the forces from here, all the forces coming through the ground would just go straight up the spine. There would be nothing to absorb the shock, right? Versus when it's a curve, it's kind of more like an accordion. When there's forces coming from one way, forces coming from the other, the spine can kind of go in its curves and absorb the shock and be a little more bouncy. So you want a curved spine, but not too much of a curve, but you don't want a straight spine. So in this picture, the part that I want you to know is this side. So we talked on the very first day about lordosis and kyphosis. Now, when you have too much of those, they become kind of more injuries or postural issues. But they actually are what the curves are called. So a lordosis is going to be an anterior curve. So we can see that the front of this vertebra is curving anteriorly. While thoracic is going to have a kyphosis, a kyphotic curve, meaning it's going to curve posteriorly. So it kind of arches back. It then comes back around to lumbar, which will be doing the same thing as the cervical. It will have a lordotic or lordosis curve. And then sacral goes back to thoracic and becomes kyphotic. So basically cervical curves anteriorly, thoracic curves posteriorly, lumbar anterior, sacrum posterior. And your coccyx really doesn't do anything, it's just chilling there. So it's when we have too much of kyphosis, too much of lordosis, then it becomes an issue with like the sway back and the hunchback. And we do have some injuries where these curves get disrupted. So if we lose the lordotic curve of our back and we start to have a straight back, then we end up having an injury. In the cervical vertebra, a lot of people are actually getting like hyperlordotic necks, where if you ever have noticed some people kind of like stick their head out front, they're having a big issue with their cervical spine. So any deviation from the normal curve will kind of result in an injury. Okay, this is kind of the more nitty-gritty, difficult part. So each vertebra is going to have its own bony landmarks. This is going to be the general vertebra landmarks. So each region, cervical, thoracic, and lumbar, are going to have specific things on their vertebra that make them different than all the rest. But these are what most all the vertebrae are going to have generally. So if we start off, this is looking at kind of an anterior view of the, or not anterior, sorry, superior view of the vertebra. So we're looking straight down on it. This is a lateral view. We're looking at the side. So all vertebrae are going to have a vertebral body. Now this is kind of the main part of it. That's what we'll see if we're looking here. This whole part of it, this whole front, that's the vertebral body. That's kind of the thick portion of it where everything else attaches off of. We're going to have our vertebral foramen, which, does anyone remember what I said about foramen? What it means? It means hole. So right here, just kind of, we're moving posterior. So posterior to the vertebral body is going to be the vertebral foramen. Can anyone guess what runs inside this vertebral foramen? What's super important in your spine? The spinal cord. So your spinal cord is what's going to run in that vertebral foramen. So it's trying to be protected by the vertebral body, being protected by all of these pokes sitting right in here. So now you can see why if you break something in your spine, it could potentially be very bad because it could attach to your spinal cord. So our pedicle is going to be next. That's what's basically going to attach the vertebral body onto all of the rest. So this right here is going to be that pedicle. So attaching onto the rest of the body. We're going to have our processes. We're going to have our spinous process, which is the point going posteriorly. So this is what you would feel when you feel the back of your spine and you feel all those bumps. You're feeling your spinous process. So all of these kind of pokey ridges, those are all of our spinous processes. And you can see just by looking at the skeleton that each region kind of has a unique shape for each spinous process. We're going to have our transverse process, which, what did transverse mean? Horizontal. Come on, guys. So our transverse processes are going to be the pokes coming transverse, out the sides, horizontal. So we can see up the sides, we got all of these little processes poking out. So you can see on here, those transverse process coming out of each side. In between the transverse process and the spinous process, we're going to have the lamina. So the lamina is going to be this region in between. So basically, if we follow the spinous process, where it starts to kind of fork out into two sides, the base of it is basically going to be the lamina. And then we're going to have our articular processes. So if you remember what the word articulate meant, articulate is when two bones touch each other. So the articular processes are basically where the vertebrae are going to touch each other and stack. So we'll have superior articular processes, which we can see on this view pretty good. So that's where the vertebra above it will sit. And we have the inferior articular processes, where this one will sit on the next. So the inferior articular process of maybe L1 is going to articulate with the superior articular process of L2. Okay. Any questions on that? Okay. So talking about how each region has unique kind of characteristics of them. So the cervical vertebra are the most unique out of all of them. So you can see we have 4 different kind of types of the way that cervical vertebra will look. The most unique is going to be our C1 and our C2 vertebra. So our very first 2 vertebrae coming from our spine to our skull. So our C1 and our C2 actually have special names. The atlas, which is C1, and the axis, which is C2. So what is unique about these is C1 doesn't really have a spinous process. It has a very large vertebral foramen because this is where kind of the brain stem is coming out of the skull and thinning out to become the spinal cord. So it needs a bit more room. And you can see we have very large superior articular processes because it's sitting on the skull. So the skull has to sit into these. The C2 is very strange because it has this superior process called the dens. Basically, it's like a little finger sticks straight up and goes through the inside of the atlas. So the C1 and C2 are the most easily recognizable. So these are some other characteristics of how to recognize cervical vertebra if you saw them individually. So they have a very oval, concave body, basically meaning they're kind of like shallowed out. We can see they have a small vertebral body. It's oval in shape. But the most unique thing that identifies cervical vertebra is that they have transverse foramen. So I just quizzed you on these 2 words. What does transverse mean? Horizontal. What does foramen mean? Hole. So we have 2 holes on their transverse processes. So you can see all of them have that. Transverse foramen right here. No other vertebra has those 2 holes. So people say that the cervical vertebra kind of look like frogs, and that these are kind of the frog eyes. So if you see these holes, you know it's going to be cervical. The other unique thing with the cervical vertebra, they have a stumpy, so short spinous process, but it is bifurcate. So bi means 2. Basically, this means that the cervical vertebra spinous process wings out into 2 little prongs. So if you come up here, eventually you can see it pretty well on some of these. They kind of have a little poke coming out versus these are just one smooth thing. The cervical will bifurcate and have 2 points. So that will make it the most unique. And also, our 7th cervical vertebra is the easiest to identify because it has the longest spinous process. So if you feel the back of your neck, you can probably feel you got that vertebra right here, right? That sticks out more than any other one. So if you've ever done back squats with a bar, you've probably hit that with the bar and it's probably gotten sore. That is your 7th cervical vertebra. It sticks out more than any other. So when you're palpating on a person or touching them, you'd be able to identify that one really easy because it sticks out so far. But all the rest, you can just count it down and be able to figure it out. So the cervical vertebra look like frogs. The thoracic vertebra look like giraffes, in my opinion. So what makes the thoracic vertebra unique is they have a heart-shaped body. So you can see their vertebral body is going to be more of a heart shape. They're also going to be generally kind of more slender looking. So you can see it looks a lot more kind of skinny and long. So they're going to have a large, very slender spinous process. So you can see their spinous processes tend to be a little more skinny coming down, and often a lot of theirs actually come skinny and project down inferiorly versus going straight out. And they're going to have costal facets. So you can see on the sides of them, they're going to have these little notches on the sides of their vertebral body. Costal is referring to ribs. So your ribs attach onto your spine in the thoracic region on those costal facets. So you can kind of see it better if you come inside the rib cage. You can see where the ribs terminate onto the spine. And you can get some issues there as well. You can also see that they have a very circular vertebral foramen, and they kind of have a lot larger transverse processes, and they also have a costal facet on there as well. So heart-shaped body looks a lot skinnier, more slender, very circular vertebral foramen, and they got those costal facets. Versus the lumbar vertebra, which just looking at it, you can tell how different it looks going from that to that. So it has a very thick, big oval body. So its vertebral body is much larger. It's going to have a very large and stumpy spinous process, so very thick and short. And its transverse processes are going to be more blade-like, coming out a lot sharper and skinnier out the sides than the others. But the really easy thing is just look at how big it is compared to the rest. And it has more of a triangular shaped vertebral foramen. Okay. Now the spinal cord does travel through all of those vertebral foramen, comes out of the brain to the brainstem, becomes the spinal cord, travels within that vertebral foramen. But, which you might not have known, your spinal cord actually ends around L1, L2. So that's why if you have a severe injury below L1 or L2, you're generally not going to have any paraplegia. So you're not going to have any paralyzation. Versus the higher up you have, the more it will take out. So your cervical vertebra control your arms, and your thoracic vertebra control basically all the nerves in your trunk. And then all your lumbar vertebra have all the nerves that house everything down below. So if you have a fracture that results in damage to the spinal cord up in the cervical region, you're probably going to have like paraplegia, paralyzations within your arms and everything below that. If it's in your thoracic region, you'll probably have use of your arms a bit, but you'll have paralyzation, everything below that. And then when we get to lumbar, as long as we're below the termination of the spinal cord, you're pretty safe. But if you get it kind of in the midpoint, you may result in some issues. So that's why when you hear that people fractured their C1 or C2, that's the most severe because that's the very start. So if you break that and damage the spinal cord at that level, you're paralyzed all the way down. You have no nerves to do it. Okay, so the sacrum and the coccyx are pretty easy. They're kind of like the patella in that they have the base and the apex, which again I think are switched in my brain. So we do know the sacrum is pretty easy to identify. I think it looks like a stingray. It has all the holes coming down the side. You can kind of see maybe where it used to be vertebra. So like maybe these used to be spinous processes. You can kind of see where the distinction would be, especially in the coccyx. You can see how it would be 4, so like 1, 2, 3, 4. But the base of the sacrum is the top flat portion where L5 is going to sit. And the apex is going to be the tip. Generally, you refer to the sacrum, you're just going to say S1. So you've probably heard L5-S1. That is the last lumbar vertebra sitting on top of the sacrum. So a lot of people will get a herniated disc, perhaps, at the L5-S1 level, which is the last disc. Okay. And then our thoracic cage, which I said is going to be our ribs, and our sternum, which is our breastbone. So within this, what you need to know is that the sternum is made up of 3 pieces: the manubrium, the body, and the xiphoid process. So you can see our sternum right here, straight down the center. It looks like a tie, right? So our manubrium is going to be the very top region. So kind of like the knot of a tie. So manubrium at the very top. Body is going to be the kind of straight and flat aspect running down the center. And then it's going to end in the tip, which that little tip point is that xiphoid process. And of course, we know that the whole function of the thoracic cage is to protect the heart, which is sitting here, and our lungs, and then our kidneys. So it's protecting our internal organs. So with our rib cage, we're going to have 12 ribs. We will have 7, so the first 7 are going to be true ribs, while 8 through 12 are going to be false ribs, and our last 2 ribs are going to be floating ribs. We also are going to have, so all of this blue, which this is an actual view, all that red, is our costal cartilage. And this cartilage is what connects the ribs to the sternum. So what makes them true ribs is that they have their own singular connection to the sternum. So these ribs have their own costal cartilage that attaches straight to the sternum. While the false ribs all join together as one, and then they have one connection. So you can see all of these ribs, their costal cartilages point and squish together and then attach. So that's what makes them false ribs. And then our last 2 ribs are those floating ribs. So you can see they don't attach to a costal cartilage. So we can see that 11th rib right there sticks a little bit further out, but there's no connection. Same with that 12th rib. These sizes can vary based on how much room you have for them. So if you've ever gotten an x-ray, luckily for me, I've had gazillions of x-rays, so I know what my anatomy looks like pretty well. So I have very little room in between the tops of my iliac crest and my rib cage. I have like an inch. So I have about this much room between them. So I actually have what's called hyperplastic ribs, and my 12th rib is like a tiny little baby rib. It is like just enough of an inch because it couldn't fit. So if you have a bigger rib cage, you kind of had more room to build it, but your body is smart and it doesn't put bone where it's not supposed to be, and it kind of helps. So if you ever get x-rays, always ask for copies because they're pretty fun to look at. So the skull, the only things I want you to know on the skull are what I highlighted or put in red. There's a ton of stuff for the skull, but we don't really need to know that for this class. What we do need to know is our external occipital protuberance, which is a very fancy word, and our mastoid process. So our external occipital protuberance, does anyone remember occipital bone was the back of your skull? So if you feel the back of your skull, you should feel a bump. So if you've ever worn a headband, that's probably where it sits on. So that bump in the back of the skull is that external occipital protuberance, which we will have some muscles attaching to. And that is what's creating that kind of new giant bony growth because all those muscles are pulling on it. And our mastoid process is going to be kind of behind our ear. So if you feel right behind your ear, you can feel that bone poking out. That is that mastoid process. So right here. And we will have some muscles in the neck attaching onto that as well. Okay. That is all for neck and trunk part 1. We will do the muscles and the injuries on Monday. And we don't have class on Wednesday, right, because of a wellness day? Okay. These wellness days are confusing me. Okay, so I will see you guys on Monday.